Welcome, Daniel Espes, MD, PhD, coming to us from Uppsala University. And today he's going to speak to us about his clinical trials with GABA. Welcome, Daniel.
Yes, so thank you very much. So thank you very much for inviting me. And I will just share my screen so that I can show you some of my slides. So let me know when you can see it.
Yes.
Yes, so I will present one of our clinical trials that we're currently running in Uppsala, in which we're evaluating the effect of GABA as a potential regenerative therapy in type 1 diabetes. And just as a very brief background, one might ask why GABA of all the potential therapies that we could test, but there's actually quite a lot of interesting data around GABA and just beta cells. And outside of the central nervous system, GABA is found in the highest concentrations in just immune cells and beta cells. And there's a lot of data on beta cell proliferation, beta cell protection, and also immune modulation. And all of these sort of point towards a positive effect of GABA in the therapy for type 1 diabetes, both as a regenerative therapy, but also as an immune protective therapy. And there's also data suggesting that GABA could induce beta cell neogenesis or transdifferentiation from alpha cells or even from duct cells. So based on these experimental studies and also studies for isolated human islets and transplanted human islets in mouse models, we initiated a clinical trial testing the controlled release formulation of GABA, which is called Remigen, which was developed by Diamyd Medical, which is a Swedish-based pharmaceutical company, although the study is an investigator-initiated study. It's a phase 1/2 trial, and it's an open label trial. And all patients that are included are type 1 diabetics. They've been diagnosed for more than 5 years. They can have either no remaining C-peptide or maximum 0.12 nanomolars of C-peptide. So they could be both C-peptide negative or to some extent C-peptide positive. And we have currently just finished the first phase of this trial, which is a dose escalation part, in which we've included 6 patients, and they were treated for 11 days. And as you can see outlined is the sort of study protocol in brief, which is quite extensive for these patients. So we conduct hypoglycemic clamps, mixed meal tolerance test prior to the initiation of therapy. Then we do pharmacokinetic curves of GABA during the whole trial. We've conducted repeated hypoglycemic clamps, and then a mixed meal tolerance test at the end of this 11-day trial. For the low dose of GABA, we observed no adverse events, whereas for the medium dose and high dose, 4 out of 6 patients had mild but transient adverse events. Most of them were related to dizziness or the type of adverse events you would recall from benzodiazepines and similar therapies. From all of the hypoglycemic clamps, we actually sort of stumbled upon a quite interesting finding, because there are a lot of data suggesting that the activation of GABA receptors would actually blunt the hypoglycemic response or the counter-regulatory response to hypoglycemia. So that's why we had so many hypoglycemic clamps in this trial. It was more or less a safety procedure in order to make sure that there's no adverse events related to hypoglycemia. But quite on the contrary, we found that the slow release formulation of GABA actually sort of enhanced the hormonal response to hypoglycemia, which is quite fascinating. So we actually had increased secretion of both glucagon, adrenaline, and growth hormone and cortisol. We also followed the timing range with continuous glucose monitoring, but given the nature of the trial and it's just 11-day trial, there's not much change, but at least there's no increase in the time below range. So based on that, we initiated then the main study, which is a phase 2 clinical trial. And there are 3 different study groups. So we treat patients with either GABA alone in low dose or high dose of GABA, or in the third arm, we use high dose of GABA in combination with alprazolam, which is a benzodiazepine, which is a positive allosteric modulator of the GABA receptor. We strive to include 12 patients per group, and the treatment will last for 6 months. And the primary outcome is to evaluate the acute and long-term safety of oral GABA treatment, whereas the secondary outcomes are related to the possible beta cell regenerative effects of GABA. And also we included additional hypoglycemic clamps in the main study due to the findings in our first dose escalation trial. So we will also further try to evaluate the effect on the counter-regulatory response to hypoglycemia of GABA. And throughout the trial, we're of course also collecting a quite extensive amount of blood samples, plasma, including immune cells, in order to further study the mechanisms in humans, if we can show that there's a positive effect or positive indirect effect on beta cell mass, I should say. So this is the whole study outline in this very brief format. And of course, this is not something that you conduct on your own. And this is the study group in Uppsala. Just want to point out that this is a pre-COVID photo, and the remaining participants are just highlighted on their own.
That's great. This is a great group, and we're really excited to see how this continues to progress. I'd like to open it up to questions from our audience. Is anyone interested in asking Daniel a question?
Yeah, I was curious in terms of the treatment that the patients receive. Do they take the medication every day? How often are they getting the medication?
Yeah, so it's a oral formulation once a day.
Okay. Is it like, has it been studied in terms of taking it at a specific time of day that's more beneficial?
That's not something we have studied. So, but patients are instructed to take it in the morning, at breakfast, and in the study trial, that's how we administer it. And so all of our data on the pharmacokinetic profile is based on once a day in the morning.
Okay, so basically after a fasting period, essentially.
Yeah.
Okay.
Yes.
Got it. Thanks.
Is there anyone else that's interested in having a question?
I had a question, actually. Great talk. I like the overview of it. And I was interested in the hypoglycemic events that you talked about with GABA. And so I was wondering, where do you think this mechanism of action is occurring? Do you think it's the brain, and then through the, like on our nervous system, you get impacts on improvements in hypoglycemic rescue? Or do you think it's pancreas specific?
I would say that this is a rather open question. I think that the effect is probably not so much from the central nervous system, because GABA is, to a very little extent, would actually cross the blood-brain barrier. So I think it's more of a peripheral effect and most likely an effect within the pancreas. However, there could also be, since many of these counter-regulatory hormones are actually released from the adrenal glands, so if there's effect directly on the adrenal glands, is not well studied, but it could be an effect either from the alpha cells, which indirectly would affect other counter-regulatory hormones, or it could be also a direct effect in adrenal glands. But that's something that we are quite interested in learning more about. So that's why we sort of changed the protocol for the main study in order to include also hypoglycemic clamps by the end of the therapy, in order to also be able to collect more samples and blood samples in order to study this further.
Great,
Have you noticed, oh, sorry, Tiffany. Have you noticed any side effects from taking the medication in terms of other off-target effects that maybe is induced by taking GABA?
Not that we're, I mean, the effects that we have observed so far are more closely related to sort of what we would you would call adverse events that would like be quite directly related to the intake. I can actually show you a table.
Oh,
so
okay.
these were the type of I expected that question. so these were the adverse events that we registered for the dose escalation part, and most of them are sort of like dizziness, like flush, palpitations, tiredness and stuff like that, but they were transient. So most of them would occur like within 30 minutes of intake of the study drug, or 30 minutes of that, and then they would like fade away over the next hour or so.
Got it.
But that for the dose escalation, that was just an 11-day therapy, whereas in the main study so far, the profile has been similar to that, but we have so far just included half of the patients for the main study, due to, well, mostly due to the pandemic and the problems related to that.
Yes, thank you for being prepared.
Yeah.
Does anyone else have a question? I had a quick question, in terms of the oral formulation of this, is there any, obviously taking a pill in the morning would be a lot easier than taking an injection, but has anyone explored, Daniel, has anyone explored giving GABA in kind of like a patch type formulation?
Not that I'm aware of. No, I'm not aware of that.
And Diamond is really focused on this, approach. I see, right? I've been watching what they've been up to. So let's hope that you guys move forward with this and that it comes to market. It'd be really interesting and a great, addition to therapy, or even who knows what it'll be, but it will be really great to see it get to market and to be able to scale to market. So thank you so much for bringing us up to date. Is there any shout out? Do you need more participants once the COVID situation calms down a bit?
Yeah, so we're still in recruiting. So we're still recruiting patients. It's a single center trial, so all patients need to come to Uppsala. So, but we're still recruiting from all over Sweden, which is, of course, from a US standpoint, quite small country, but still we try to recruit patients from all over our nation, and we still need more patients for the trial. But currently, the pandemic is hampering the inclusion of patients, but we're still hoping to finish the inclusion by the end of this year.
Yeah. Well, sorry. Go ahead.
I was curious about, because you mentioned that your patients are usually diagnosed with type 1 diabetes at least 5 years or more. I think that's what you said. I was curious on how you came up with that timeline, and that you're not including patients that maybe been more recently diagnosed, what the reasoning was behind that.
So since our main ambition, like the first goal of the study is to study the safety of the therapy. So, but otherwise we're most interested in the regenerative capacity of GABA in humans. So we don't want the beta cell mass to still be in decline. And like for most patients, at least if you're GAD positive, you would have reached sort of a plateau after 5 years. So at least your rate of beta cell decline is quite stable. So that was like the main cause for that. But I would say that GABA is still very interesting also in the new onset phase, since it has these immune modulatory effects, which could have it could potentially also have a beta cell protective role in the early onset of type 1 diabetes. But since our main interest in this trial is to study this regenerative capacity, we sort of want the onset to have occurred at least 5 years prior to study initiation.
Got it. So maybe another future study for those that have just been diagnosed.
Yes, that could be another trial, which would be very interesting.
Yeah.
But currently, like, that sort of interfered with another trial we're running. So we'll see.
Well, I think it's really important also that you are looking at potential drugs for people who have had the disease for so long. I would say a majority of those that are being tested are for that unique group that have just been diagnosed. So the fact that you are working with people who have had it for longer gives some hope that there's still options for people that maybe have had the disease for longer. So I think it's really important that what you're doing.
Yeah, I agree on that, because there's also, I mean, I'm enthusiastic about all intervention trials in type 1 diabetes, and like there's vaccine trials in order to prevent onset, and then there's the protective trials, but there's also a great need for trials that are aiming at all stages of diabetes, because I mean, you're pre-symptomatic to a certain point until you're diagnosed, and then you're new onset type 1 diabetic for just a very brief period of time. And if you miss that window of opportunity, then that type of therapy is no longer available for you. So, and that's also why we include both patients that are C-peptide negative and to some extent have remaining C-peptide. And although we might be short in numbers, but what we're sort of aiming for is to see, are there really signs of a transdifferentiation also in humans? Meaning if you're C-peptide negative at start with both a clinical measure of C-peptide and a ultrasensitive measure of C-peptide, and we can then start to observe C-peptide over time, that would at least be sort of a indirect sign that beta cells are awakening or are transdifferentiated from other sources. Of course, that
Are you looking at other indicators of beta cell like regeneration or like revival, in the sense of maybe if patients have a less insulin intake or total daily dose in that regard? I know some people have mentioned that maybe the gold standard of C-peptide might be, challenging to achieve, but if we can achieve maybe some of these other milestones in terms of, not taking as much insulin, that might be really useful too.
Yeah, so we're definitely tracking all those parameters like insulin needs, HbA1c, and but for the main exploratory outcomes are related to C-peptide and C-peptide response to mixed meal tolerance tests, since that is sort of like the gold standard.
Yeah.
Since also, I mean, you could reduce insulin needs by just making people feel really sick and stop eating. Then, so that's the, I mean, but of course, in combination with patients are doing fine, HbA1c is getting better, and you're still reducing insulin needs. That's really something. And something that I find really intriguing is that if we can, like, the science that you would increase the counter-regulatory response to hypoglycemia, if that's also true in the main study, that could also be a important factor for improving metabolic control, since hypoglycemia is often an obstacle to reaching optimal glucose control. So that could also be an important key for improving metabolic control, even though if you don't increase your own endogenous beta cell mass.
Okay. I'm actually not sure what a hypoglycemic clamp is. Do you mind explaining what that is?
Basically, it's just an infusion of insulin at a fixed rate, and then you would alter the infusion of glucose. So the patient would come in the morning, and then you would first target glucose levels to 5.5 millimolar, which would be, I'm trying to guess now in milligrams per deciliter. The conversion factor is 18, so it should be something like, but then, so like a normal glucose range, and you would sample that for 30 minutes. That would be like baseline samples. And then you would reduce the infusion of glucose so that your glucose level would drop to around 2.5 millimolar. I think that would be like 55 milligrams per deciliter. And then you would stay at that level for 30 minutes and then sample the hormone response again.
Wow.
So it's sort of an induced hypoglycemic event.
Yeah, because I'm familiar with like intravenous glucose tolerance tests and that kind of thing, but the hypoglycemic clamp seems much more complicated.
Yes, so it requires quite extensive monitoring, since you could, like the response to hypoglycemia can differ, and we also so it has to be done in the hospital, of course, but it's a good way to sort of sample the counter-regulatory response to hypoglycemia.
Got it. Thank you.
Daniel, has anyone looked at dual use of, two drug use, such like, using the GABA along with teplizumab or something like that, a two-pronged approach earlier in the disease process when like one biomarker has been, seen?
You mean pre-onset of disease, like when you have an autoantibody positive?
Right, because like look at prevention is coming in now with their approach to try to keep people sort of in remission, and you just wonder, has anyone addressed sort of piggybacking something like a GABA on top to, like, because you're drawing attention to the fact that it increases beta cell mass, so right, that might be a two-pronged approach.
Yeah, so there's also experimental data suggesting that it also increased beta cell survival for different models of type 1 diabetes, and also in relation to transplantation of islets, that it actually decreased the beta cell death after islet transplantation, which is of course a completely different mechanism than the autoimmune response. But I'm not aware that it's been used in like the pre-symptomatic phase, which would be possibly it could be an ongoing trial, but I haven't seen any results from that yet. So
so much work to be done, but we got to get rid of this pandemic.
Yeah.
So that's really where it comes down to. Does anyone else have questions for Daniel? All right, then. Well, we'll stop here, and thank you so much for talking to our group. I really appreciate it.
Yeah, thank you very much, and thank you for the invitation and all the questions.
Thank you.